PSA is not a cancer test. It is a prostate signal, and several very different things can turn it up. Cancer can raise PSA, but so can an enlarged prostate, inflammation, infection, ejaculation, cycling, recent procedures, and certain medications. One high result can therefore mean serious risk, temporary noise, or simply more prostate tissue producing more PSA. The mistake is jumping from high PSA directly to cancer. The other mistake is explaining it away and never finishing the investigation. Today we are building the modern PSA ladder. Decide whether screening makes sense, obtain the cleanest measurement possible, repeat an unexpected result, refine the risk, use MRI selectively, and biopsy only when the combined evidence justifies it. If you appreciate calm health information that replaces panic with a decision tree, tap like, tell us in the comments whether you have ever had a PSA scare, and subscribe to Longevity Compass. First, PSA stands for prostate-specific antigen. It is a protein produced by normal prostate cells as well as cancerous ones. There is no single number that cleanly divides cancer from no cancer. Cancer can exist below 4, while benign enlargement or inflammation can push PSA above 4. Only a tissue biopsy can definitively diagnose and grade prostate cancer. PSA opens the door to an investigation, it does not deliver the verdict. That is why screening is a shared decision rather than an automatic annual ritual for every man. A major 2026 Cochrane review found that PSA screening probably prevents about 2 prostate cancer deaths for every 1,000 men screened. Roughly 500 men would need to be invited for screening to prevent 1 death. But screening also produced about 36 additional prostate cancer diagnoses per 1,000 men, many involving slow-growing tumors that may never have caused harm. So PSA screening offers a modest chance of preventing death, balanced against false alarms, biopsies, anxiety, overdiagnosis, and possible treatment side effects. Before ordering the test, ask what you would do with the answer. Screening only helps when the pathway after the blood draw is thoughtful. Current urology guidance supports discussing a baseline PSA around age 45 to 50 for many average-risk men. Higher-risk men may begin the conversation around 40 to 45. Higher risk includes Black ancestry, a strong family history, or certain inherited variants such as BRCA2. Black men in the United States are more likely to develop prostate cancer, are often diagnosed younger, and are more than twice as likely to die from it. Family history becomes more meaningful when a father, brother, or son was affected, especially at a young age, or when metastatic prostate cancer clusters with breast, ovarian, or pancreatic cancer on either side of the family. That pattern may justify genetic counseling, not just more frequent random blood tests. Now suppose the PSA comes back high. Before anyone starts planning surgery in their imagination, look for temporary influences. Ejaculation can raise PSA for a short period, so avoiding it for about 48 hours before testing is reasonable. Long or vigorous cycling may also cause a temporary increase in some men. Prostatitis, urinary infection, urinary retention, cystoscopy, or a recent prostate biopsy can raise PSA more substantially. Finasteride and dutasteride lower PSA and require adjusted interpretation, while testosterone therapy and other hormone-related products may change the context. An asymptomatic man should not automatically receive antibiotics simply to see whether PSA falls. Antibiotics are for suspected bacterial infection, not a diagnostic coin toss. The next step after a newly elevated PSA is often the most underused one. Repeat the test. Current urology guidance recommends confirming a new elevation before ordering a biomarker, MRI, or biopsy. Across studies, approximately 25 to 40% of newly elevated results return to a non-elevated range when repeated. The repeat may occur around 6 to 8 weeks, although infection, procedures, urinary retention, and the size of the elevation can change the timing. Repeating PSA is not procrastination. It is quality control, provided the repeat actually happens. Use the same laboratory when practical. Avoid ejaculation and vigorous cycling beforehand. Make sure urinary symptoms, recent procedures, and every medication or supplement are disclosed. If the repeat normalizes, that is reassuring. It is not a lifetime guarantee, especially when family history, symptoms, examination findings, or previous trends remain concerning. If PSA stays elevated, the next move is not automatically biopsy. We refine the probability. PSA velocity measures how quickly PSA changes, but it should not be used alone as a biopsy trigger. A sudden jump can reflect inflammation, laboratory variation, or temporary biological changes. A trend matters. A social media velocity cutoff does not get to make the entire decision. PSA density adds prostate size to the equation. It divides PSA by the volume of the prostate. A PSA of 6 from a 30 ml prostate produces a much higher density than the same PSA from a 90 ml prostate. More gland tissue can produce more PSA without cancer. A density near 0.15 is often discussed, but it is not a magic border. MRI quality, age, examination, family history, and the rest of the risk profile still matter. Percent-free PSA can also help when total PSA is in a borderline range. Lower percentages are generally more concerning, while higher percentages tend to suggest lower risk. Newer tests such as Phi, 4K score, ISO-PSA, ExoDx, and other urine panels can estimate the likelihood of clinically significant cancer. But do not order a biomarker merely because it exists. Order it when a high or low result would actually change whether MRI or biopsy happens. Now prostate MRI. Multiparametric MRI can identify suspicious areas and help direct biopsy needles toward them instead of sampling the prostate entirely at random. In the Precision trial, an MRI-based pathway found clinically significant cancer in 38% of men compared with 26% using standard biopsy. About 28% of men in the MRI pathway had a non-suspicious scan and avoided immediate biopsy. MRI also reduced detection of low-grade cancers that were less likely to need treatment. That is an important improvement because the goal is not to discover every microscopic cancer cell. The goal is to find cancers likely to threaten health while disturbing fewer that would remain harmless. But a clean MRI is not a force field. MRI accuracy depends on the scanner, protocol, radiologist, tumor location, prostate size, PSA density, and the person's baseline risk. A negative MRI lowers risk, it does not reduce it to zero. Persistent substantial PSA elevation, high PSA density, an abnormal examination, a strong family history, or a high-risk mutation may still justify biopsy. When MRI shows a suspicious lesion, targeted samples are usually taken. Systematic samples may sometimes be added because a targeted biopsy can miss disease elsewhere in the gland. If biopsy finds low-risk cancer, treatment is not automatically the next step. Active surveillance is now the preferred approach for many appropriately selected low-risk cancers. It can include repeat PSA testing, examinations, MRI, and follow-up biopsy, with surgery or radiation reserved for evidence that the cancer is progressing. Active surveillance is not ignoring cancer. It is refusing to create permanent urinary or sexual side effects for a tumor that may never become dangerous. Watchful waiting is different. It is generally used when age or other health problems make curative treatment unlikely to provide meaningful benefit, with treatment focused on symptoms if they develop. Now symptoms. Difficulty starting urination, a weak stream, frequent nighttime urination, or incomplete emptying are often caused by benign enlargement, not cancer. But persistent symptoms still deserve evaluation. Blood in urine or semen, inability to urinate, fever with urinary symptoms, painful ejaculation, persistent pelvic pain, or unexplained hip or back pain also deserve medical attention. Symptoms change the pathway from screening to diagnosis. A previously low PSA should not be used to dismiss a new clinical problem. Here is the clean decision tree. Average risk and no symptoms. Discuss baseline screening around 45 to 50. Then choose an interval based on PSA, age, health, and preferences. Higher risk. Begin the conversation earlier, often around 40 to 45, and include ancestry, family history, and possible genetic risk. 1 Unexpected elevation. Check temporary causes and repeat the PSA before jumping to biopsy. Persistent elevation. Combine the repeat value with prostate size, %free PSA, examination, family history, validated risk calculators, and selective biomarkers. Meaningful remaining risk. Use prostate MRI when appropriate. Suspicious MRI or persistently high risk despite a negative MRI. Discuss targeted and possibly systematic biopsy with a urologist. Low-risk cancer. Ask whether active surveillance is safer than immediate treatment. If this helped replace one frightening number with a rational pathway, check the description for our Amazon KDP book and practical tools for organizing family history, medications, laboratory trends, and questions for your next appointment. PSA is valuable when it opens the right door. It becomes harmful when one imperfect result is allowed to sprint past confirmation, context, MRI, and judgment.